Dr. Mohammed?
Okay, so first off,
may I introduce you?
No, go ahead.
I will introduce you, sir, and Professor Dunlop. Bismillah ar-Rahman ar-Rahim. It's a great honor to be with us tonight. Two eminent speakers, Professor Douglas Dunlop from Southampton University and Mr. Mohammad Amer from Southampton University, in a very interesting topic, overview of hip revision surgery, tips and tricks. Thank you very much for being with us tonight, and with us moderators tonight, Dr. Rami Sharif from Fremley Park Hospital and Dr. Hussam al-Iksiri from Banha University Hospital. We will start with the talk of Dr. Mohammad Amer. May you start, please, sir?
First off, Assalamu alaikum. I would like to thank Professor Ashhab and Banha University Trauma and Orthopedic Department for this kind invite and opportunity. My name is Mohammad Amer, and I'm the current hip fellow to Professor Dunlop at UHS. I would like also to confess that I am a double agent, as I'm an assistant lecturer of trauma and orthopedics, Cairo University Hospitals. So you can think of our presentation today as a two-course dinner. My presentation is the appetizer, where I'll briefly discuss methods of reconstruction, Paprosky Classification, and Professor Dunlop decision-making algorithm. And then the main course will be the prof presentation, where he will turn on the time travel machine, take us through 20 years of revision hip surgery, where we will see most of the reconstruction techniques in the book, as well as the evolution of the prof's practice with advancing technology. And hopefully by then, we will leave you full and satisfied. So if we were to imagine an ideal reconstruction method, it would be one that would give us a stable fixation, allow me, the surgeon, to place the components in appropriate position and version to achieve the optimum stability and biomechanics, and will theoretically outlive the patient and ideally would preserve or even restore bone stock. So you can classify them into biological and non-biological. Biological means that the component osseointegrates with host bone, and that requires a stable fixation, viable host bone, as well as host bone component contact. Examples of that would be a cementless cup, trabecular metal augments, and HA-coated implants. Non-biological does not require osseointegration between the component and host bone. There's no host bone component contact needed. However, fatigue resistance is needed. Examples of that would be impaction grafting and a cage cup construct. It is important to know that there is no right or wrong way. It is like driving on the left or the right. It depends on the road, which is the patient in this case, and the driver, which is the surgeon's experience. You can also mix both methods with each other, as we will see in Prof's presentation. So it is always wise to start off with a classification. It gives us a strong base to build on, as well as unifies our terms. The most relevant is the Paprosky Classification. It is a radiological classification based on 4 radiological signs on the AP X-ray. First off is the proximal migration of the center of rotation, which is measured as the perpendicular distance between the center of rotation to the superior obturator line, which is a line connecting between the superior obturator angle on both sides. It is all, and then it measures the proximal migration of the center of rotation. The other line is the Kohler's line, which is a measure of the medial migration of the component. The other two is the ischial lysis, which is again the perpendicular distance from the superior obturator line extending to the lower end of the lysis, as well as, and it signifies posterior column defects. Teardrop lysis, which signifies anterior as well as medial wall defects. It is very useful, as it is useful in preoperative planning, decision making, and translates well in terms of intraoperative findings. And this is the table. However, it's a bit confusing putting all 4 radiological markers together, so you have to put them together through a mind map. So we'll start off by looking at the proximal migration, whether it is more or less than 2 to 3 centimeters. If it is less than 2 to 3 centimeters, then this is a Paprosky 1 and 2. And you can see here that the vertical distance, a perpendicular distance, is less than 2 centimeters, which means that you've got a supportive rim and column, which means, according to Paprosky, you can go with a cementless or a jumbo cup. You also have to look at Kohler's line, which signifies medial translation of the components. And if there is a defect in Kohler's line, then you should think about protrusio in terms of your approach, the proximity of the sciatic nerve to your dissection, as well as the difficulty in dislocation, as well as the risk of fracturing the femur. Moving on to more deeper waters, when you've got proximal migration more than 2 to 3 centimeters, so that's either a Paprosky 3 or a pelvic discontinuity. And that means you don't have a supportive rim or column. It can be broadly classified into 3As and 3Bs with pelvic discontinuity. It can be either up and out, which is a Paprosky 3A, and you can see here that the center of rotation is migrating proximally from the superior obturator line, as well as laterally from the Kohler's line. And it also has some ischiolysis, which denotes some posterior column loss. The other variant is the up and in hip, which means that the Kohler line is disrupted, which is a Paprosky 3B and a possible occult pelvic discontinuity. It's really important in these cases to get a CT scan that will enable us to judge the defect better. And sometimes it can be accompanied by a teardrop lysis, which signifies anterior column injury. So this is a 3B, where you can see the center of the hip migrating proximally as well as medially. And this is a pelvic discontinuity, where you can see a visible fracture line following failure. So the drawbacks of Paprosky classification: it is an algorithm designed for cementless revision. It treats X-rays, not patients. It does not take into account the patient age or the need for future revisions. So I think the most important thing to take out of this big slide is to look at the proximal migration, whether it is a 2 or 3. If it's less than a 2, then it's a 1 and 2. You can consider cementless revision with primary standard implants. If it's more than 2, then you look at the hip, whether it's up and out, which is a Paprosky 3A, which is classically treated according to Paprosky with a cup and an augment. If it's up and in, then you need a CT scan and you need proper planning, because this is the most complex revision. And it's important to know that on this side of the channel, cementless hemispherical cups are not enough. So now this is Prof's practice in terms of his decision-making algorithm, and he takes into account the patient age as well as the need for future revisions. So we'll start off by looking whether we've got proximal migration, which is more or less than 2 to 3 centimeters. If it's less than 2 to 3 centimeters, then we go for a jumbo cup. But if the patient is young, we would consider impaction grafting, with the hopes that in 10 to 15 years, when this hip fails, we can convert it easily into a jumbo cup. If the proximal migration is more than 2 to 3 centimeters, then we ask ourselves, can we reconstruct this socket with one augment? And if the answer is yes, we usually go for a cup augment construct. However, again, if this patient is young, we can consider impaction bone grafting with a mesh or an augment or a cage, with the hopes that in 10 to 15 years, when this hip fails, we can do an easier revision with a cup augment or even a jumbo cup. However, if it needs more than one augment, then in today's or Prof's current practice, we would prefer to use a custom 3D implant. So moving over to the femoral side of things, again, this is the Paprosky classification for femoral bone loss, where you start off with type 1, where you've got minimal metaphyseal bone loss, type 2 extensive, type 3, you've got metaphyseal, diphyseal loss with more than 4 centimeters of the supportive diaphysis, type 3B less than 4 centimeter, and type 4 is the ectatic femur. For type 1 and 2, you can use an extensively porous coated implant, and that's according to Paprosky. For 3As and 3Bs, you can use a uncemented taper fluted implants, just the restoration of the Wagner. And for type 4, according to Paprosky, it's either a impaction grafting or a proximal femoral replacement. However, the Paprosky classification again does not take into account the need for future revision, the patient's age, or whether the implant is cemented or cementless. Again, this is our current practice, or what I think is the prof's practice. We go through, if you've got a femoral revision, you look at this, whether the stem is cemented or uncemented. If it's cemented, you look at the cement mantle, whether it's intact or not. And if it's intact, which can be assessed radiologically as well as intraoperatively, which the prof is going to elaborate on that further, you can consider an in-cement revision. If this is a revision for an uncemented implant and the cement mantle is not intact, then we ask ourselves the following questions. So what is the femur morphology and bone quality, which is the Paprosky classification? What is the patient age? What was the cause of failure? What is the plan with the acetabulum? And whether there was infection or not. So we can go with a cementless taper fluted implant for an older patient with supportive diaphysis. We can go with impaction bone grafting for a younger patient to preserve bone, but you wouldn't go for that option when you are doing a big job on the socket side. You can go for a proximal femoral replacement for an older patient with an unsupported femur who is not expected to outlive the implant. Or you can go for an uncemented long stem with a locking option for an older patient with an unsupported diaphysis who is expected to outlive a proximal femoral replacement. And by now, I think you're done with the appetizer, and I think it's time for Prof. Dunlop to take over.
Thank you so much, Mr. Mohammad Amer, for this very nice appetizer. Thank you so much.